welcome you. Today, we're embarking on a deep dive into a concept that's absolutely fundamental to global health, yet often holds surprising layers of meaning. Primary healthcare.
hmm
Think of it as the bedrock upon which healthy communities are built, but maybe with a revolutionary spirit baked in.
That's a good way to put it. Revolutionary for its time, definitely.
We've pulled together some incredible sources for this deep dive, offering a really comprehensive look at the core definitions, the guiding principles, and a fascinating real-world case study.
Right.
We'll look at how primary healthcare is put into action, particularly in a country as vast and diverse as India.
The scale there is something else.
And we'll also zoom out a bit, connect it to major global initiatives like the Millennium Development Goals and the Sustainable Development Goals.
MDGs and SDGs, yeah.
Yeah.
Crucial links.
Our mission today is to truly unpack what primary healthcare means, why it was and still is so transformative, and how it aims to provide essential care widely and equitably. Hopefully you'll have some genuine aha moments.
I think you will. What's truly fascinating about primary healthcare, or PHC as we'll often call it, is how it fundamentally shifted the paradigm.
Shifted how?
Well, away from traditional disease-focused medical care,
Yeah.
Hospitals and specialists.
Okay.
It moved us towards a more holistic, community-oriented approach, making healthcare universally accessible, which was a really radical idea back then.
Okay, let's unpack that radical idea then. What is primary healthcare exactly? Our sources really emphasize a specific foundational definition established way back in 1978.
That's right. This foundational definition emerged from the joint WHO-UNICEF International Conference in Alma-Ata in 1978.
Alma-Ata.
And it defines PHC as essential health care based on practical, scientifically sound, and socially acceptable methods and technology,
Right.
made universally accessible to individuals and families in the community through their full participation.
Full participation, that sounds key.
And at a cost that the community and the country can afford to maintain at every stage of their development in the spirit of self-determination.
Wow, that's quite packed. Self-determination, even.
It is. And this wasn't just, a simple definition. It was really a blueprint for global health equity.
A blueprint.
The true aha here is that in 1978, PHC fundamentally reframed health. It wasn't just about treating sickness in hospitals anymore.
Okay.
It was about integrating all aspects of well-being, clean water, nutrition, education, directly within communities.
So much broader than just medicine.
Exactly. This made health a societal responsibility, not just a medical one. It really laid the groundwork for what we now widely understand as the social determinants of health.
Oh, okay.
It really is the very first level of healthcare, designed to be available to everyone, right where they live.
That definition truly sets the stage for a new way of thinking. But what are the core principles that really differentiate primary healthcare from, say, older health systems? Our sources highlight several key ones.
Exactly. These principles are what make PHC so distinctive and, frankly, so enduring.
Like what?
Well, one of the first is equitable distribution.
Equity.
Equity.
Got it.
This means health services should be shared equally by all, not just concentrated in cities or for the wealthy few.
Right, addressing that imbalance.
Yes, it aims to correct those historical imbalances, actively shifting resources to rural and underserved urban populations. Because historically, health services did really favor urban dwellers. PHC seeks to redress this social injustice, as the documents sometimes call it, by ensuring widespread reach. Think about the vast networks of health centers you see in rural India, for example.
Okay, so equity is number one. What else?
Then there's community participation or involvement.
Community participation.
This is about actively involving individuals, families, entire communities in promoting their own health.
Actively involving them. How?
Well, the idea is that universal coverage just can't happen without local community involvement in planning, implementing, even maintaining services. You maximize local resources that way.
Makes sense.
It's often powerfully phrased as health by the people,
Health by the people. I like that.
or placing people's health in people's hands. It's about empowerment.
That sounds almost radical for systems that often feel so top-down. How do you actually get that kind of community buy-in?
It's crucial, and it takes specific mechanisms. In India, for instance, this is really well illustrated by programs like the Village Health Guide scheme from way back in 1977,
Okay.
and more recently, the Accredited Social Health Activist Program, the ASHA program.
ASHAs, yes, I've heard of them.
Right. ASHAs are local women, trained to mobilize their communities, help people access services like immunizations, provide basic care for minor things, and they're depot holders for essential drugs like ORS, oral rehydration salts.
So they really are the link.
They absolutely bridge that gap between the community and the formal health system. And similarly, you have trained ADASM local birth attendants who conduct safer deliveries and offer family planning advice.
Okay, so equity, community participation. What's next?
Another core principle is intersectoral coordination.
Intersectoral meaning.
Meaning, achieving comprehensive health requires efforts far beyond just the health sector itself.
Ah, right. Like education, water.
Exactly. PHC emphasizes collaboration with sectors like agriculture, education, housing, public works, you name it. It needs strong political will, of course.
I bet.
And it often involves reallocating resources across different government departments.
Can you give an example of that?
Sure. A prime example from India is the Integrated Child Development Services Scheme, or ICDS.
Oh, CDS, okay.
This delivers a whole package of services: nutrition, immunization, health checkups, preschool education, through collaboration across different departments. It's not just the health ministry doing it alone.
Got it.
And addressing those broader social determinants, we mentioned literacy, sanitation, safe drinking water, that also falls squarely under this principle.
Makes sense. Anything else principle-wise?
Well, we also see the principle of self-reliance emerge. It's not always listed separately, but it's sort of inherent in self-determination and people's involvement.
Self-reliance, how does that play out?
It basically means empowering communities and individuals to take responsibility for their own health. So, for instance, an emphasis on self-care, like people monitoring their own blood pressure or blood sugar if they have the means that reduces the burden on the official services.
Right, moves beyond just passive care.
Exactly. Active management. And community participation itself leads to communities actively planning and even evaluating their own health services.
Okay. And you mentioned one more.
Finally, there's nationwide coverage. This principle speaks to the aim of universal accessibility, ensuring that PHC truly reaches everyone, everywhere, or at least strives to.
So equity, community participation, intersectoral coordination, self-reliance, and nationwide coverage. Those are the big guiding ideas.
Those are the pillars, yes.
So if those are the principles, how do you actually build this? What are the concrete building blocks or elements of primary healthcare? Our sources outline 8 essential components from Alma-Ata.
Right. These 8 elements are designed to be integrated at the community level to really improve health outcomes.
Okay, what are they?
So number 1, education on prevailing health problems and how to prevent or control them.
Education first. Makes sense.
2, promotion of food supply and proper nutrition. Absolutely fundamental. 3, an adequate supply of safe water and basic sanitation. Still a huge issue globally.
Definitely.
4, maternal and child health care, which is vital and includes family planning.
Okay.
5, immunization against major infectious diseases, a cornerstone of public health.
Yep.
6, prevention and control of locally endemic diseases, malaria, TB, things specific to a region.
Right, targeted.
7, appropriate treatment of common diseases and injuries, basic curative care.
Okay.
And number 8, crucially, the provision of essential drugs, making sure people can get the basic medicines they need.
So those 8 are the core package, so to speak.
That's the core package from Alma-Ata. But what's important to note is that these aren't totally rigid. They can be modified for local circumstances.
Oh, adaptable.
Yes. Some countries have even expanded this list to include things like mental health, care for physical handicaps, and care of the elderly, reflecting changing needs.
Now, understanding these foundations is one thing, but seeing them in action, that's often where the real insights emerge. Our sources give us this fascinating deep dive into how PHC isn't just theory, but a massive living system. We're talking specifically about implementation in India, structured in that very specific 3-tier approach you mentioned earlier to try and reach everyone.
Yes. India's experience is incredibly instructive. As a signatory to Alma-Ata, they're deeply committed to PHC.
Right.
The system, which is largely governmental, aims for universal, comprehensive, and affordable healthcare. And it's evolved significantly over time, especially with major initiatives like the National Rural Health Mission and, more recently, Ayushman Bharat.
Okay, so walk us through that 3-tier structure again. How are health services actually organized and delivered level by level?
Certainly. So health services are organized at 3 main levels, and referrals typically go upwards as the health issue gets more complex.
Okay.
The primary healthcare level is the first point of contact. It's closest to the people right in their communities.
Grassroots level.
Exactly. Then you have secondary healthcare. This handles more complex problems.
Hmm.
It's the first referral level, usually provided by things like district hospitals and community health centers.
Okay, the next step up.
Right. And finally, tertiary healthcare. This offers super specialist care at regional or central institutions. Think highly specialized services, teaching hospitals, that sort of thing.
Got it. Primary, secondary, tertiary. So let's really focus in on that primary care level, especially in rural areas, which is often the biggest challenge.
Yeah.
What does that look like on the ground in India?
Okay. The rural health infrastructure is built on a network of several key facilities and personnel. You've got subcenters, primary health centers, PHCs, and community health centers, CHCs. But starting right at the village level, you had these crucial frontline workers. We mentioned the accredited social health activist, ASHA, before.
Yes, the ASA.
Think of them as the community's immediate health resource.
Yeah.
There's typically one for about every 1,000 people. They are local women trained to mobilize the community.
Mobilize how?
Well, encouraging people to use health services, providing basic care for minor ailments like diarrhea, fevers, giving first aid. They're also depot holders for essential supplies like ORS and iron folic acid tablets.
So they actually hand things out.
Yes, and their role is incredibly expansive. They refer and even escort patients to facilities. They report births and deaths, promote sanitation, support TB patients with their treatment, and provide home-based newborn care.
Wow, that's a huge job description.
It really is. It speaks directly to that community participation principle.
So if ASAs are that first point of contact, they're essentially the backbone of this system at the village level. It sounds like their role is far more than just basic care.
Absolutely. They're essential mobilizers and connectors. Also at the village level, you have Anganwadi workers, AWWs.
Anganwadi workers, right, part of the ICDF.
Exactly, part of that Integrated Child Development Services scheme. They focus on supplementary nutrition, immunization, health checkups, and health and nutrition education, primarily for young children and pregnant or nursing mothers.
Okay.
Historically, there were also village health guides, VHGs, who disseminated health knowledge and family planning supplies. And we mentioned the trained dais, the traditional birth attendants who conduct deliveries. And crucially, there are often village health sanitation and nutrition committees, VHSNCs. These committees facilitate community participation and planning right at the grassroots.
So a whole team at the village level, what's the next step up?
Moving up a level, we have the subcenter level. Now, under Ayushman Bharat, these are often being upgraded and called Health and Wellness Centers, Sub-Health Center, HWCSHCs.
HWCSHCs, got it.
This is the most peripheral formal health facility, the first contact point with the official system for many villagers. Typically, one serves about 5,000 people in the plains or 3,000 in hilly or tribal areas.
Okay, and who works there?
They're staffed by multi-purpose health workers, notably the ANM, which stands for Auxiliary Nurse Midwife.
The ANM.
Yes, A&Ms are really the backbone of frontline clinical care at this level. They provide basic health services, maternal and child health care, family planning, and treatment for common illnesses. They have essential drugs on hand.
And the upgrade to HWC, what did that add?
The upgrade under Ayushman Bharat means these subcenters now focus on comprehensive primary health care. So beyond the basics, they handle antenatal and postnatal care, immunization tracking, follow-up for various health programs, a broader scope.
Okay, so village, then subcenter HWC-SHC. What's next?
The next level is the primary health center PHC level, also being upgraded to HWC PHC.
Okay, the PHC proper.
Right. One PHC typically covers a larger population, maybe 30,000 in the plains, 20,000 in tougher terrains. They serve as a referral point for several subcenters.
And their function?
They're designed for quality, preventive, promotive, curative, supervisory, and outreach services, a step up in complexity.
Who runs the PHC?
They're manned by a medical officer, or MO, usually a doctor.
Ah, the first doctor in the chain for many.
Often, yes. The MO leads the health team at the PHC, assesses the community's health needs, provides curative care, handles minor surgical procedures, family planning services, including sterilizations, manages common conditions, first aid, and emergencies.
And the upgrade to HWC PHC, what did that bring?
That was a big shift, too. With Ayushman Bharat, these upgraded PHCs now offer significantly expanded services. Crucially, this includes screening and management of non-communicable diseases, or NCDs.
NCDs, like diabetes, hypertension.
Exactly. Hypertension, diabetes, even common cancers like oral, breast, cervical. This is huge, bringing NCD care down to the primary level.
That is a big change.
Yeah. They also provide basic oral health, eye care, ENT services, mental health screening, and even geriatric and palliative care support. They're leveraging things like teleconsultation to connect with specialists, and they have more diagnostic tests available.
Wow, so much more comprehensive.
It's a major move towards comprehensiveness. And the Indian Public Health Standards, or IPHS, define the norms for staffing, equipment, and services for all these facilities, PHCs, CHCs, subcenters, aiming for a certain standard of quality.
Okay, so that's the PHTH, WC, PHC level. Is there another primary care level?
Well, the final step, often considered part of the primary referral network, bridging to secondary care, is the community health center, CHC level.
CHC. Right.
A CHC typically serves a population of 80,000 to 120,000, often covering a whole community development block or CD block. It acts as the first referral unit for about 4 PHCs.
So if the PHC can't handle it, you go to the CHC.
Exactly. CHCs are staffed by specialists, usually a surgeon, a physician, a gynecologist, and a pediatrician.
Specialists, okay.
And they're better equipped. They typically have 30 indoor beds, an operation theater, X-ray facilities, and a laboratory.
So they can do more complex procedures.
Yes. They provide crucial services like emergency obstetric care, essential for complicated deliveries, full family planning services including surgical methods, and safe abortion services.
That's an incredibly intricate and detailed structure, really designed layer by layer to try and reach everyone.
It is. It's a massive undertaking.
What were some of the major policy drivers or programs that really pushed this system forward or shaped it over the years? You mentioned NRHM and Ayushman Bharat.
Yes, several key initiatives have been pivotal. The National Rural Health Mission, NRHM, launched back in 2005, was huge.
NRHM, right.
Its main goal was to improve rural health care, making it more accessible, affordable, and accountable. It integrated many previously separate vertical health programs like TB or malaria control under one umbrella and significantly strengthened the infrastructure, especially subcenters and PHCs. ASAs were also introduced under NRHM.
Okay, so NRHM was foundational. And Ayushman Bharat.
Ayushman Bharat, launched in 2018, has 2 components, but the relevant one here is the Health and Wellness Centers, EBHWCs.
The HWCs we've been talking about.
Exactly. This represented a major paradigm shift towards comprehensive primary health care. The goal was ambitious, establishing 1.5 lakh, 150,000 HWCs by upgrading existing subcenters and PHCs.
150,000.
Yes. And these centers are vital now for expanding services, especially for NCDs, TB, leprosy screening, and management. They're designed to bring care much closer to people's homes. At the sub-health center level HWCs, they're often headed by a new cadre called the Community Health Officer, or CHO.
CHO, okay. Any other key strategies?
Well, there's the Reproductive, Maternal, Newborn, Child, and Adolescent Health, RMNCH plus A strategy from 2013, later updated to RMNCH plus N to include nutrition.
RMNCH plus A.
This really emphasized a continuum of care approach linking services from the home and community level right up through the different facility levels, ensuring smooth transitions, especially for mothers and children.
A seamless journey, ideally.
That's the aim. And finally, the National Health Policy 2017 explicitly envisions these HWCs as the foundation of India's health system. It emphasizes that shift from selective care, just focusing on a few big problems, to comprehensive care, aiming for free essential drugs and diagnostics at these centers and focusing on developing the necessary health workforce.
So a real push towards comprehensive, accessible primary care through these policies.
Definitely, a clear policy direction.
But despite all these comprehensive measures, this massive infrastructure, these policies, are there still significant challenges? Does the system face hurdles in actually delivering on the promise of PHC?
Oh, absolutely. Our source points to several ongoing challenges. There's still a historical entrenchment of a curative culture.
Meaning people wait till they're sick.
Yeah, people often seek care only when they're ill, rather than focusing on prevention or early detection. Changing that mindset takes time.
Okay. What else?
There's also still a high concentration of health services and personnel in urban areas, despite efforts to correct it. This leads to persistent disparities between urban and rural access.
The urban-rural divide.
And related to that, there are ongoing shortages of health manpower, doctors, nurses, specialists, especially in rural and remote regions. Staffing these thousands of centers consistently remains a major hurdle.
Right. Resources and staffing, always a challenge.
Always.
So, stepping back from the specific case of India, what does all this mean in the bigger picture of global development?
It's fascinating how primary health care directly ties into those major international initiatives you mentioned, the Millennium Development Goals and the Sustainable Development Goals.
Absolutely. If you connect PHC to the bigger picture, it's crystal clear that health is a central driver of development. It's not just an outcome, it enables everything else.
Right.
The Millennium Development Goals, MDGs, which were adopted way back in 2000.
The MDGs, yeah, except for 2015. Exactly. There were 8 ambitious international development goals agreed upon by, I think, 189 UN member states, aiming for achievement by 2015. And they truly placed health right at the heart of global development efforts. They really acknowledged its foundational role.
And how specifically were health issues addressed in the MDGs? Were they broad targets or pretty specific?
They were quite specific, actually. 3 of the 8 MDGs were directly health-related.
3 out of 8. Oh.
And all the others, poverty, education, gender equality, had indirect health effects, of course. But the specific health goals were:
What were they?
Goal 4 aimed to reduce child mortality. And they had clear indicators, like the under 5 mortality rate, infant mortality rate, measles immunization rates, very tangible measures.
Okay, child mortality?
Goal 5 was to improve maternal health.
Huh.
Here, the indicators were the maternal mortality ratio and the proportion of births attended by skilled health personnel, really focusing on safe childbirth.
Maternal health. Got it.
And Goal 6 focused on combating HIV/AIDS, malaria, and other major diseases. Things like HIV prevalence, condom use rates, the impact of AIDS on children, and tracking prevalence and death rates for malaria and tuberculosis.
So, child health, maternal health, and major infectious diseases. That was the MDG focus.
That was the core health focus, yes.
So what happened after 2015 when the MDG timeline wrapped up? How did that global health agenda evolve?
Well, the MDGs were succeeded by the Sustainable Development Goals, SDGs, adopted in 2015 as part of the 2030 Agenda for Sustainable Development.
The SDGs. We hear a lot about those.
Yes. And health is centrally positioned again, but the approach is different. Instead of multiple health goals, there is one comprehensive health goal, SDG 3.
Just one. SDG 3.
Yes, SDG 3. Ensure healthy lives and promote well-being for all at all ages. It's deliberately broad.
Well-being for all at all ages. Okay.
And within SDG 3, there are 13 specific targets covering all major health priorities. It's much more expansive than the MDGs.
13 targets under one goal.
And 4 of those targets specifically represent the sort of unfinished and expanded MDG agenda, things like reducing maternal mortality further, ending preventable newborn and child deaths, fighting epidemics like AIDS, TB, malaria, but also adding things like hepatitis and waterborne diseases.
So building on the MDGs but broadening out.
Exactly. And critically, one of the targets, SDG 3.8, is achieving universal health coverage, UHC.
UHC, that seems directly linked to primary health care.
Absolutely. UHC, ensuring everyone can access the quality health services they need without financial hardship, is seen as the keystone. It's fundamental to achieving all the other health targets in SDG 3 and building resilient health systems overall. PHC is essentially the main strategy to achieve UHC.
Got it.
And one other key difference. Unlike the MDGs, which primarily focused on developing countries, the SDGs are universal. They apply to all nations, rich, poor, middle income.
So a global commitment for everyone.
Yes. It really expands the scope of global responsibility for health equity.
That was a truly comprehensive deep dive into primary health care. Really fascinating. We've seen how this powerful concept, born back in 1978, continues to evolve and drive global health initiatives, from those core principles like equity and community participation to the incredible multi-tiered systems trying to deliver it on the ground in places like India.
Sheer mechanics of it.
All the way to shaping these ambitious global goals like the SDGs and the push for universal health coverage. It really is a continuous journey.
It absolutely is. And that raises, I think, an important question for you listening. If health by the people is a core tenet of primary health care,
right,
what active role can you play, not just in managing your own individual health, which is important, but in advocating for or supporting the health of your broader community?
Good question.
It really challenges us to think beyond just our personal medical care and towards collective well-being as a shared responsibility. How do we actually put health in people's hands in our own contexts?